I think we all appreciate our population is ageing. If we look at our own population projections in Ireland, so these are figures from the Central Statistics Office, and this graph shows the percentage change in population by age from 2020 to 2045. So the greatest change in population growth over the next 25 years will be in the older age groups. I think most striking is the number of people aged 85 and over living in Ireland will increase over the next 25 years by 268% for men, shown in blue, and 181% in women, shown in pink. So this ageing demographic will obviously have an impact across all areas of society, all areas of healthcare, and particularly so in oncology, where nearly 60% of all cases and 70% of cancer deaths occur in those aged 65 and older. So how are we currently managing our older patients with cancer in Ireland? Well, these are figures from the National Cancer Registry, published in 2016. And it shows the percentage of patients having tumour-related surgery, chemotherapy, or radiation therapy within a year of diagnosis between the years 2008 and 2012. And it compares the treatment received by patients aged 75 and older and those aged 45 to 54. So we can see that for all cancers, 9% of younger patients receive no treatment at all, compared to 42% of older patients during that time. If we look specifically at chemotherapy, so nearly half of younger patients received chemotherapy, compared to only 14% of older patients. And I think this difference is particularly striking if we look at our most common cancers. So only 13% of older adults with lung cancer and 8% of those with breast cancer received chemotherapy, compared to nearly 2/3 of younger patients. And we see the same trend across all other cancer types. So older patients are less likely to receive chemotherapy, radiation and surgery. They're also less likely to be referred by GPs for treatment, and they're less aggressively screened. And it's all of these factors that likely contribute to the poorer survival that we see with increasing age for all cancer types. So patients aged 75 and older are nearly 4 times more likely to die from their cancer than patients aged 45 to 54. So I think this is very sobering data, and it does raise the question as to why is there such a disparity between how we treat older and how we treat younger patients? And I think this disparity actually reflects just the complexity of the treatment decisions in older patients. I suppose firstly, as doctors, our primary aim is to do no harm. And the data is fairly consistent now that although older patients do garner the same magnitude of benefit from chemotherapy than younger patients, it is at the cost of increased toxicity. So I think we often err on the side of caution and maybe don't undertake an active therapeutic approach in our older patients. The other major challenge is that as we age, the issues here all become far more relevant, and all of these issues can affect not only how patients tolerate, but whether they benefit from the treatments we can offer. So older adults are more likely to have memory problems and depression. Functional status and mobility are more likely to be impaired. As we age, our social support network can often decrease, and we are more likely to accumulate comorbidities and, as a result, polypharmacy. So I suppose we in oncology need to change our approach to older adults, and we need to take all of these factors into consideration when we're assessing a patient's fitness for treatment. And we can do that through comprehensive geriatric focused assessments, in addition to our standard history and examination. So if we can actively seek out deficits in these areas, we can then apply practical interventions to manage them, but we can also use this information to personalize our treatment decisions in the oncology setting. So the comprehensive information that we gain from these assessments, it can help us better stage the aging. And I suppose hopefully get the balance right between over and under treating our older patients. So we may stage the patient as fit and they should undergo standard therapy. On the other hand, we may deem them clearly frail where best supportive care is appropriate. And I apologise if my use of the term of supportive care isn't correct following the talk by Professor Davies this morning. You then have the whole spectrum in between these extremes where a modified approach may be more appropriate. So in other words, it's this spectrum of vulnerability in older people that should guide our treatment decisions as in older patients with cancer as much as the stage of the cancer itself. So what are the benefits of this oncogeriatric approach? Well, first of all, it allows us to detect problems which would not be found on our routine history and examination. So it allows us to be proactive as opposed to reactive in managing these problems and thus optimize the patient medically and then give them the very best chance of tolerating and benefiting from the treatments we offer. This approach can also result in decreased toxicity for patients, improved quality of life, decreased ED attendances, and decreased hospitalizations. So we now have randomized data presented at ASCO last year showing the benefit of this approach in achieving all of these outcomes. So I'm going to go through these 3 studies fairly quickly. So these were 3 large studies presented, as I said, at ASCO last year. So they were all slightly different in their design, but essentially all patients due to start chemotherapy were randomized to a standard of care arm or a geriatric intervention arm. So the intervention arm involved a comprehensive geriatric assessment with recommendations made on the management of any deficits found. So these results were then provided to the treating oncologist and the decisions on chemotherapy treatment were made with the benefit of these results. So in the larger 2 studies, the primary outcome was toxicity, and in the 3rd study, the primary outcome was quality of life. So what were the results? Well, in the largest study, the GAP70 study, 50% of patients in the intervention arm experienced a grade 3 to 5 toxicity over 3 months, compared to 70% in the standard of care arm. So there was a 20% reduction, keeping in mind that grade 3 toxicity is toxicity that leads to hospitalization. Grade 5 toxicity leads to death. The GAIN study also met its primary endpoint, where the overall incidence of grade 3 to 5 toxicity was 50% in the intervention arm and 60% in the standard of care arm. Again, a 10% reduction in significant or life-threatening toxicity. In the final study, so patients in the intervention, so this was the primary outcome here was quality of life, and in the intervention group, patients reported significantly better quality of life scores than the usual care group across all of the follow-up time points. I think what was particularly striking in this study is the secondary endpoints. So in the intervention arm, there was 39% less emergency presentations, 41% less unplanned hospital admissions, and 24% less unplanned hospital overnight bed stays. So we now have randomized data showing the benefit of these geriatric assessments. And I think these are extremely important outcomes for older adults. And in this very vulnerable population, we need to move away from overall survival as being the only important outcome. We know in older adults that hospitalizations often lead to functional decline. And if you actually look at the general medical literature, we see that even though patients may be successfully treated for the disease that puts them in hospital, up to 1/3 of patients are discharged with an ADL impairment, which can impact their ability to live independently. So methods to minimize toxicity and avoid hospitalization are extremely important outcomes in this group, hence why these studies are important. So then on a practical level, how do we use this information and translate it into the clinical setting? Well, I thought I'd show you how we changed our approach to our older patients in Waterford. So in 2017, we set up the Geriatric Oncology and Liaison Clinic, and it's a clinic that's been constantly changing and evolving over the years. At present, all patients referred into the medical oncology service who are 70 or over are contacted by phone by our advanced nurse practitioner, Michelle Hannon. So they undergo a screening assessment using this tool, the G8. So this is a very simple questionnaire. It contains 8 questions shown here. They include things like weight loss, BMI, age, medications. So the total G8 score lies between 0 and 17. So the higher the score, the better the health status. So this has a threshold of 14 points. So meaning that if a patient with a score of 14 or less, then they should be considered for a full geriatric assessment. So in our clinic, we do the G8. Patients who are deemed fit by screening attend our standard oncology clinic, whereas those that score 14 or less are deemed vulnerable on screening and they attend the Gold Clinic, where we formulate an integrated treatment plan. So the first step in the clinic is to see the advanced nurse practitioner. She does the patient's observations, takes a detailed history, and does a battery of geriatric assessments, which I'll go through in a minute. So then referrals are made to other services where appropriate from the geriatric assessment findings, and the patient sees the medical oncology team with the benefit of all of these assessments. Finally, for any patients with specific issues of concern, we do have a sessional commitment from a geriatrician once a week to discuss those patients in detail. So in terms of the assessments we do, so this is just an example. These are the domains we assess, so cognition, mood, functional status, mobility, social support, nutrition, and polypharmacy. We use a series of validated tools shown here, and there are a huge number of tools that we could use. These just worked best for our service. So for example, with cognition, we do the mini-cog, which is just a 3-item recall test. We also take a detailed collateral from the patient's family or GP. If we find any deficit, we go on to do a more thorough assessment using the MOCA or Montreal Cognitive Assessment. We do a battery of bloods, and these are the patients where if we identify a significant deficit, we sit down and discuss with the geriatrician, or we refer them on to the memory clinic, and we have fast track set up into that service. If we look at something like nutrition, we do the mini nutritional assessment. And again, if we identify any deficits, we have fast tracks to the dietitian. In terms of medications, we take a history from the patient. We also ring the GP and the pharmacy. And then our pharmacist does a full drug reconciliation, looking for any drug interactions or identifying any drugs that may be stopped. So we then use all of this information to help us choose the best treatment for our patients. So we use a chemotoxicity calculator. So this looks at things like the patient's tumour and treatment variables and lab results such as hemoglobin and creatinine, but it also looks at some geriatric assessment variables. So things like function, psychological state, social supports and hearing. So this calculator, which is freely available online, it predicts the risk of grade 3 to 5 toxicity, and it quantifies this risk, so into low, medium or high risk. And this information is really useful. So it not only helps us as physicians to help direct our treatment decisions, but it's also really useful in our discussions with patients and their families, where we can better actually kind of quantify the risks of the treatment to them, and I suppose hopefully help them make more informed decisions. So is all of this time well spent doing these assessments? I suppose keeping in mind that these are issues we would not identify on our routine assessments. In the 148 patients that have come through this clinic, 38% have had some degree of cognitive deficit, albeit most of these are mild. About 13% had signs of depressive symptoms. In terms of functional status, about a quarter of patients had at least one deficit in ADLs, and a half of patients had at least one deficit in their IADLs. We look at falls, which can be a sign of frailty. 14% of patients reported a fall in the last 6 months. And then on functional assessment, using the timed up and go, half of patients were at risk of falls. So this is a very significant finding when we're considering chemotherapy, which can further increase their falls risk by causing fatigue, neuropathy, etc. So linking in early with OT and physio is very important in these patients. I suppose finally, we look at nutrition, and only 14% of patients that we have assessed have had a normal nutritional status on assessment. 55% were at risk and 31% frankly malnourished. I think it's interesting to look at this nutritional data in a little bit more detail. So if we look at the BMI of patients of those at risk of malnourishment, most patients were normal, overweight or obese on their BMI. Similarly, for those patients classed as malnourished, only 15% actually had a BMI below normal. Finally, if we look at polypharmacy, so 70% of patients were on more than 5 medications. And again, this is very relevant when you think of all of the supportive medications that may be added in to manage the side effects of chemotherapy or the symptoms of the cancer itself. So upfront, we stop any unnecessary medications and we identify any interactions with planned new therapies. So I've just shown a sample of some of the assessments we perform, and as you can see, we gather a huge amount of information. So I just want to show you 2 patients that have come through the clinic and how this information helped us personalize their care plans. So the first patient was Edward. He was an 86-year-old man with a stage 4 colon cancer. He had liver and lung metastases. In terms of his comorbidities, he had hypertension and was taking antihypertensive medications in addition to pravastatin and aspirin. He lived with his wife, he was a non-smoker and drank about 2 to 4 units of alcohol per week. He had an ECOG performance status of 1, and on examination, he had a non-tender hepatomegaly. Around the same time, we also saw Patrick. He was a little bit younger at 79. Again, he had stage 4 colon cancer with lung metastases. In terms of his comorbidities, again, he had hypertension and high cholesterol. His medications included antihypertensives. He was on a statin and was on omeprazole and a weaning dose of steroid. In terms of his social history, he lived alone. He did have 3 children, 2 of whom lived nearby. He had an ECOG performance status of 1, and on examination, he had decreased air entry in the left lung, but again, examination was otherwise fairly unremarkable. So here we have 2 men with very similar disease and disease stage, and very little to differentiate them on our standard history and examination. Even with our eyeball test, they were very similar. So we went on to do a geriatric assessment. So Edward had normal cognition with a MoCA of 27/30, no signs of depression. He was independent for his ADLs and his IADLs. He had no history of falls and his timed up and go was 9 seconds. So he did have some signs of nutritional compromise with an MNA of 9, and he had an excellent social support network. So the standard treatment for this gentleman would be a doublet of chemotherapy. So his risk of significant toxicity with a full dose doublet therapy was 54%, so a high intermediate risk. If we changed that and gave him single agent chemotherapy, that risk fell to 44%, so it's still a low intermediate risk. So with this gentleman, we opted to start slow and start with single agent chemotherapy with the option to escalate depending on tolerance and response. We linked him in up front with a dietitian who followed him throughout his course. He remained on treatment for 3.5 years with intermittent drug holidays. So these drug holidays weren't because of toxicity. He was an avid racehorsing fan, so he would stop his chemo, go off to a meet, and then decide when he was ready to come back on treatment. So he had an excellent quality of life. And this was Edward at 89.5, and sadly he has since passed away. So the next gentleman was Patrick, again, very similar on our initial assessment. This gentleman did in fact have signs of cognitive impairment with a MoCA of 17/30. And on talking to the family, they had noticed some issues, particularly with short-term memory. He did show signs of depression, and again, on contacting his pharmacy, he was taking mirtazapine. He was independent for his ADLs, but did need help with taking his medication. And he reported 2 falls over the prior 12 months. He did show signs of nutritional compromise, and he had a very poor social support network. He did have 2 children living nearby, but they were both working and just weren't readily available to him when needed. So again, looking at his risk of a significant or life-threatening toxicity, with just single agent chemotherapy, his risk of toxicity was 86%, so a high risk. Even with a dose reduction, this fell to 77%, remaining in a very high risk category. So with this gentleman, we opted to not to proceed with chemotherapy and focus on symptom management. Again, we linked him in with the dietitian. Given his falls history, we referred to OT and physio. We linked in with the GP and public health nurse to arrange things like home help, a personal alarm, etc., and referred to palliative care. We also liaised with the geriatrics team. So he had 2 admissions over the next 3 months, one with a respiratory tract infection and associated delirium. He subsequently did have another fall at home and unfortunately died in hospital. So these assessments allowed us to better stage these 2 gentlemen who had very similar disease. Both had an ECOG performance status of 1, and both very similar on our baseline assessments. And hopefully we got the decision right and didn't under or over treat. So I'm aware I've about 2 minutes left, so I'm going to conclude. Cancer is a disease of older people. The outcomes for older cancer patients are poor, and this is in part due to less extensive investigation and treatment once they're diagnosed. I hope I've convinced you of the benefits of geriatric focused assessments and interventions that can lead to us being more proactive in identifying and managing non-cancer problems. They can allow us make more informed decisions. So from the doctor's perspective, make a decision in terms of who to treat with chemo, and as important, who not to treat. And also from the patient's perspective, where they can better weigh up the risks and benefits of the treatment. These assessments can lead to reduced toxicity, less hospitalizations, less emergency room department visits, and better quality of life. So I'll leave you with some photos of some of the amazing patients that have come through our clinic in Waterford, and I'm happy to take any questions.